Hey there, listeners. Welcome back to Let's Get Oral. I'm Jonathan Dornell, one half of the LGO crew. In today's episode, we continue our IDM Totality of Care series by sharing our conversation with Dr. Joseph A. Puma, the founder and president of Sorin Medical. With over 30 years of clinical experience, Dr. Puma has dedicated his career to the treatment, diagnosis, and prevention of heart disease. In this conversation, we further explore how his career as a cardiologist has evolved to further implement the practices and principles of oral systemic health. So without further ado, here's our conversation with Dr. Joseph Puma. Thanks for listening.
Let's get oral. Let's get oral. Hello, we're still at the Totality of Care here in Knoxville, Tennessee. And right now we're with Dr. Joseph Puma, who is a cardiologist. And I'm excited to talk to you because anytime we're talking about oral systemic health, we really need to talk about the whole body as it relates to the health. And so I love that you're here at this oral systemic conference. Tell me about your journey as a cardiologist and how you came to be at a conference like this.
Well, first, thank you for having me. Nice to see you, Camille and Jonathan. I appreciate the opportunity. I'm an interventional cardiologist, and much of my career, I deal with the end result, the damage that's done from atherosclerotic heart disease, blocked arteries, hardening of the arteries, everyone knows, the widowmaker lesions. I've been involved in cardiology before we had stents and we were just doing balloon angioplasty. So it's been really quite a journey. Several years ago, Dr. Gina Pritchard, and Dr. Victor Avis, who were really promoting oral systemic health, and I want to circle back to that term for a second. They were meeting with me and educating me really over time about prevention and different biomarkers and how we can improve patient outcomes and patients' lives by preventing them from ending up or delaying severe heart disease, delaying them to really need interventional treatment. But I think really the key is until I really spoke with them several years ago, no one ever really presented it as oral systemic health. Right? The dentists, for the most part in this country, live out on little islands.
Yes.
Yep.
Right? Unlike, when you're sick and you go to a hospital, there's loads and loads of doctors. We all run in packs, where dentists are like lone wolves out there. And that's just a structural issue of kind of the way practice has been. Dentists are primarily in private practice. And even where there's dental programs in medical centers or academic medical centers, they tend to be smaller, not integrated into the mainstream. Research and education isn't quite as integrated as we would like. And so the whole concept seemed quite unique, and it was certainly something different to think about, or to think about these issues in a different way.
Right. That is one thing that I've noticed. All the speakers here, their unique journeys are basically them being curious about what else could be contributing to these pathologies that we're coming in late for treatment, and how to kind of get upstream of there to intervene. So what does your practice look like now that you're more focused on prevention?
So we have, in our practice, we have very aggressively taken to analyzing heart disease before patients have symptoms. And now the technology has really brought us to this point where it's feasible, cost-effective, and super high quality. And so patients at any age can come and get a a Sorin heart scan. That's what we've called it, because we have the highest accuracy in the United States in terms of diagnosing and assessing coronary artery disease. But basically, it's a 3-minute CAT scan angiogram of the heart. And in that way, we can assess not only if patients have blockages in their arteries, we can assess if they have calcification, plaque, the level of that calcification and plaque, and we're doing a number of research studies aggressively modifying risk factors with medical therapy, lifestyle changes, as well as inflammation reduction to reduce future events. Because really, ultimately, at the end of the day, as an interventional cardiologist or as any doctor, we can only do 2 things for patients: make them feel better or live longer. The feeling better part's actually pretty easy. People come to you when they don't feel well,
Yep.
right? The most common reason people seek medical attention in the United States is because they have pain.
Right.
And relieving that pain, you don't have to be a brain surgeon, so to speak, to do it. But making people live longer is more challenging, because in part, you have to educate them to understand how they have to participate.
I was going to say, how do you get these people with no pain to come to you and be evaluated?
Well, it's very interesting. So there seem to be 2 different populations of patients out in the world. Those, your typical show up once in a while to the doctor, or show up when they don't feel well, or show up when they need medication refills, let's say, or they're not feeling well. Then you have a whole nother population of patients, and these patients usually start to emerge in their 40s or 50s, and they start to fear their mortality.
Fair enough.
and they're interested in wellness and longevity, and they're very much seeking out educating themselves, and they want prevention. They want to try and make themselves live longer in some different ways. And so even from that perspective, on the wellness side, there's a whole continuum of physicians, providers, products, and things of that nature, none of which, by the way, have proven that they improve anyone's longevity, but they all usually focus on some half-truth or some reasonable association, but hasn't been proven in terms of a treatment to improve longevity. But since COVID, the reality is that something's changed in the United States. Something's certainly changed in my communities, in that it seems all patients, no matter which bucket they were in before, are less likely to trust what they hear on television, to trust what doctors tell them. The whole system, the structural system of gaining access to a physician's appointment seems to have broken down, and they're frustrated with it.
Yeah.
Even whether you can get to see a physician, by the way.
Yeah.
The use of extenders, which are great on the one hand, but many of the hospital systems use extenders simply to reduce costs.
Yeah, I've noticed some of the urgent cares rely specifically on extenders, and the MD is remote by phone.
Yep. Further to that point, the majority of urgent care centers in the United States are owned by health systems,
Yes.
and they're kind of feeders. It's a business proposition.
Yeah.
Yep.
Into their hospital or to their doctors. And so, patients are smarter than all of this. Despite all these changes we've had in healthcare structure, despite all these changes we've had in healthcare payment systems, the one thing that hasn't changed over the 35 plus years I've been in practice is what patients want and what their families want.
Mm-hmm.
And they still want to have a connection to their doctors. They still want to know who their doctor is. They're looking for someone, trying to find someone that they can trust to help them make health decisions.
Right.
So that's kind of been a challenge.
Yeah. I mean, I can relate to being faced with mortality at 40, when, just being a late blooming mother and thinking, oh no, am I going to be around long enough? But would you think that most of your patients are kind of fit that profile where they're worried about, being around for their kids and...
Yeah, I think, some of them just worried about being around for themselves.
Yeah, okay.
All
right.
Some of them, their kids are already older.
Okay.
But I think the reason people come to us is because with coronary CT scanning now, you literally, again, in a 3-minute scan, can get an insight into the heart. And heart disease, the number one killer in the Western world by a long shot. We always get a flurry of patients coming in once their friend or relative, dies at 40 or 50
Sure.
from a sudden heart attack.
Yep.
So, but now we can really assess what their arteries look like. We could see if they have blockages in the arteries in their heart. We could see if they are calcified but not blocked up.
Right.
And then we can adjust medical therapy appropriately. And again, we do this through lifestyle assessment, diet, exercise, risk factor assessment and modification. So the major risk factors for heart disease: high blood pressure, diabetes, high cholesterol, family history, and cigarette smoking.
Yeah.
Some of which are modifiable, some of which are not. We can't choose our parents, and as some of our parents will tell us, they didn't choose us.
Indeed.
But we can't, we can modify smoking, right? Or we can work to modify that. We can modify weight loss. And even now, with new weight loss drugs that are all the rage, the reality is they work.
Mm-hmm.
And one of the reasons they work is because we don't have to rely on behavioral modification, which is so hard
It is.
for any human being to do, is to change their behavior. Smoking makes you feel good when you're doing it, even though intellectually it's not good for you in the long term. But right now, in this moment, it makes me feel good, so people do it. Same thing, if you follow me around, you'll catch me once in a while going through a McDonald's drive-through, even though I know it's
Yeah.
not good, and I don't do it every day or every week. But boy, is it delicious.
Absolutely.
And those French fries are delicious. And but high blood pressure with medical therapy as well, cholesterol with medical therapy as well. The challenge is, though, how do we, so what we really want to do is prevent all of this.
Right. So when do you want to see your patient? How old would you want?
So I take the position that I'm here to help, and anyone who wants to see me, I'm going to help.
Okay.
Okay, and I don't want to put parameters on that. From an oral systemic health standpoint, it's been an epiphany working with people like Dr. Victor Avis and Dr. Gina Pritchard,
Yes.
Laura Hooper. They refer as many patients as any internist or general cardiologist does to us. And part of it, I think, is a very good grounding in a general assessment, kind of back to what patients really want. They're sitting there and talking to their patients.
Mm-hmm.
They're assessing proper lab work.
Right.
They're looking at inflammation. And from a dentist perspective, they're probably they're probably best positioned than any healthcare professional to assess for obstructive airways and sleep apnea. And we know all of these things cause health problems, and in particular heart disease.
Right.
And so if there's a way to integrate or to collaborate, the real question would be, why wouldn't we do it?
Right. Do you also refer out to any dentists in the area?
We absolutely do. Now, again, typically, I've spent my career on the wrong end of health.
Right.
Right. It's always, especially when you're training.
We call it salvage, right?
Yes. You're in the hospital, and you don't have to be too smart when you get that code blue or something, or they call you that someone's having a heart attack in the emergency room. Like, everybody knows what to do.
Right.
Okay. It's not even that hard to make the diagnosis anymore. But it's very hard to change the way you think when
Yes.
you've been conditioned to work in that way, and you're busy every day working that way. So even on the oral health perspective, often I'd only refer patients if they had poor dentition, or especially if they were going to need open heart surgery. Then we really
Yes.
need to ensure that there's no dental infections. if patients had valvular heart disease. And so cardiologists are always, to some degree, even if it's passive in that way, working with dentists. Since I've been involved and getting more educated and with the Totality of Care Symposium, you're really learning how to integrate that a little, take it to the next level, to the next step. How can we both help improve patients' care? The reality is, in terms of feeling better, probably the best way is on the sleep apnea side, obstructive airways.
Yes.
That's clearly something that makes people feel bad, even if they don't realize how bad they feel.
Yes.
After it's treated, they always come back and say, geez, I didn't realize how tired I was. I didn't realize what low energy I had. I didn't realize I wasn't breathing well. Whereas on the inflammation side, periodontal care, oral care, that's more an inflammatory issue, and it's a little bit harder to define.
Yeah. Well, and periodontal disease doesn't necessarily hurt, so.
Right, and that's my point.
Yeah.
So that's kind of a live longer
Yeah.
issue. But now using our heart scan, combining assessment, everything we usually do, blood work, history, physical exam, lifestyle assessment, and recommendations, lab work, inflammatory markers. Now we get a coronary CTA. And we really have a full context for the patient. And we have some tools where we can even give them a 10-year risk of a heart attack, stroke, or death.
Goodness.
Not everyone's open to hearing about it. But that's, we have to be humble in terms of what we actually can accomplish.
Right.
And those are things that we can accomplish. But on the research and education side, I think there's lots of research avenues. Let's go back to inflammation and go back to oral health. And as we were talking a little bit before we started the podcast, more than 20 years ago when I was on faculty at the Duke Clinical Research Institute, we did a large randomized trial in people who had already had a cardiac event, a heart attack, that survived. And we would test their blood to see if they had chlamydia pneumoniae, which is a bacterial infection, usually colonized orally.
Mm-hmm.
And then we gave them a 3-month course of oral antibiotics. And we compared outcomes over 3 years, followed them for 3 years, patients who received the antibiotic and those who did not, to determine the risk of another heart attack, stroke, or death. And initially, the curves separate, and it looks like if that oral infection, which leads to inflammation, increases cardiac events, right?
Yes.
We know all of that.
Yeah.
And initially, at least, it appeared that treatment with antibiotics was beneficial, but over time, the curves kind of come back, and so it wasn't statistically significant benefit. But I think we gave up too fast because we know there's association between oral flora, chronic infection, inflammation in the whole body, which contributes to coronary artery disease and events, right? Having coronary artery disease on the one hand isn't so bad as long as it doesn't lead to heart attacks.
Right.
Because it's the damage, right? The explosion in the artery, which threatens your life and reduces your lifespan. So I think there's plenty of avenues for future research, education, collaborative, bringing together internists, cardiologists, dentists together, things that we can do together that will advance the science and hopefully improve patient outcomes.
Through your journey, have you noticed other heart peers of yours paying attention and finding their own ways to integrate oral systemic health practices in their realm?
So that's a great question. What I can tell you is in our practice, there's, I believe, 15 or 16 of us physicians in our practice. And they're now going through the eye-opening phase like I did when, for instance, we had a recent meeting and, we talk about the patients that are referred to us. And we're always blown away, the patients referred by the dentist to us that have this severe disease and really need care and treatment, when these patients were being seen by an internist or a general cardiologist, right? So there's a gap.
Yep.
Right? But I don't think we get over that gap. Or, there's a gorge and we have to jump it, but building that bridge is going to take time.
Yes.
It's going to take effort, right? I mean, we've all been through school and we all know education is painful, costly,
Yep.
and time-consuming.
Yeah.
But the best way to finish is just to get started. And it seems like, there's a group here that are getting started and are true believers, and they're promoting it. And as long as you recognize that you don't know what the end point is ultimately going to be, right? Because as it was in that research trial that we did, it was good science. We had a good basis for it. It was funded by a pharmaceutical company. They spent a lot of money, and the trial failed.
Right.
But that didn't mean the idea is wrong. And
Right.
that just meant, this is a chronic problem, right? An everyday problem. Your mouth never goes away. It's not like treating a pneumonia where you get an infection in your lungs, you have a 7-day or 10-day course of antibiotics, and you expect it to be gone and not to come back again.
Right.
So who knows what, so it's going to take a lot more time and effort to figure out, what the right antibiotic might be, what the right dose is, what the right duration of treatment is.
With the inflammation story, what I find really frustrating in many of these trials that are addressing inflammation is there's no dental evaluation. And so we know that 90% of the population has some level of inflammation in their mouth, and we're not controlling for that. So I think some of our poor outcomes have to do with that relationship, because there are plenty of studies now. Glogauer initiated some of these oral studies in mice and then followed up with humans, showing that if you have inflammation in the mouth and then you have a secondary infection or insult, that secondary infection or insult is exacerbated quite remarkably. And so you really need to control where the inflammation is coming from. And a lot of times we already have it going on in the mouth, and we're not preventing. We don't really have a good grasp on oral hygiene products that may be exacerbating our oral health, because some of us are very sensitive to some of the products that we've been using for the last 70 years. And so I think that we need to do kind of a wholesale reassessment on how we run inflammation clinical trials, but also oral hygiene.
As you're talking, it brings to mind 2023, I believe it was, or the end of 2022. The first anti-inflammatory drug was approved for use in patients who suffer a heart attack, colchicine.
Yes.
We have been studying anti-inflammatory agents my entire career. I finished my fellowship in, 1989 or 1990. I spent 13, 14 years at a clinical research institute. We looked at all different types of anti-inflammatory agents. And we even, were involved in some studies with colchicine in heart disease. And as I look back over all of this, it reminded me, and when colchicine was finally approved and there was finally a trial, there was no dental input into that. And the reality is we didn't really look to see where the inflammation comes from, right?
Yes.
So here you have cardiologists or internists in one room drawing blood tests, checking CRP levels or homocysteine levels, inflammatory markers.
Yeah.
You have the dentist doing the same thing,
Yes.
as well as checking dental flora and things like that.
Yes.
And they're sending them probably to the same lab, right? They're all,
Right.
They probably, the tests go to the same lab, but then the results come back into these silos.
Yeah.
There's a lot we could probably do if we just sat in the same room together and started chatting.
Yes, please.
Because we have, we have similar interests,
Yes.
Yep.
similar goals, and the truth is, we'd probably be able to get to an answer faster, good or bad. Remember,
Yeah.
when you do research,
I know.
Yeah.
They
you
don't
come
call
up
it
with
search,
ideas that
they call
make
it
common
research.
sense,
Yeah.
but they don't always commonly happen when you do it in a controlled, randomized trial.
Right.
But that's okay, and then you move on. And it doesn't mean the idea was wrong. It just may mean it's a dosing issue. It's a
Yes.
timing
Frequency.
issue.
Yes.
Yep.
Right? It's a frequency issue.
Right. Heart
That-
medication at night or in the morning.
yeah,
Tell me.
this is a hard job.
Yeah.
Right? It's hard work, and that's why in most research institutes or most hospitals, there's not just one doctor.
Right. Yes.
There's hundreds and hundreds and thousands, and there's collaboration across the country and internationally. And so, getting back to that way, that approach, advocating more for that approach, getting more in-person meetings. Zoom is great.
Yeah.
Google Meet is great. Sitting here chatting with you, though, in person was a lot better than exchanging emails and,
Yes.
and that kind of stuff. There's a soft part to all of this that's hard to quantify and hard to measure. But all of us in this business know that, like any technology, there's a usefulness for it, but we can't let it take over everything that we do. It doesn't change writ large the way we used to do things, or it shouldn't
Right.
anyway. And meeting with our dental friends, they're professionals, they have doctorates, they work hard.
Yeah.
They've been involved in research, they care about their patients. We have to find platforms
Yes.
to have these discussions.
Are you attending any more of these types of platforms in the coming year?
I am very much at this late stage of my career a man in evolution. I could tell you that. My mother used to tell me when we were kids, we make plans and God laughs. Well, he's hysterical right now.
Okay,
right?
sure. Yes, I'm feeling it too.
Yeah.
Things don't always go the way you think they're going to go.
Yes.
Facts.
But you just have to be open. You have to be open to the change, and you have to, you have to be willing to recognize that there's still things you can learn, and knowledge and insights can come from anywhere,
Yeah.
right? They may come from Knoxville, Tennessee today, even though I live in Manhattan, and it's, and you also have to be willing and open to share what you know and your experiences, because those are also valuable. So,
What do you think the key insight that you're bringing to this conference has been?
well, I hope the key insight that I bring is that they're on the right track, but there's still a lot of confusion. I mean, it is clear, I think in terms of making people feel better, as we said earlier, the dentist should take the lead in diagnosing and putting together treatment teams for sleep apnea. They see the patients first, and they probably recognize it first before any other doctors. But if they want to be part of it, they're going to have to take the lead in coordinating a diagnosis and treatment center or some collaborative environment. In terms of making people live longer, all the oral health issues are correct. There's inflammatory markers, and there's clear epidemiologic associations. What we don't have yet are any true treatments for those associations that are measurable, that we can prove make an impact in terms of reducing the risk of a heart attack, stroke, or death. And that's the challenge. We don't have proof yet that oral care should be added as a risk factor for heart disease, even though we have a lot of...
I was going to say, I'm offended right now. We have so much research. But yeah. And we do have intervention research. We do have clinical trials that have shown that periodontal intervention can reduce the incidence of stroke and heart attack.
Yes, it can, and I don't disagree. But for instance, inflammatory markers.
Yeah.
The only clear research we have, let me say it different. Inflammatory markers have an effect on LDL, or what everyone knows as bad cholesterol.
Sure. Systemically.
That's correct. And that's largely what leads to inflammation in the plaque in the artery that can lead to heart attacks. We don't have any proven interventions to manage the inflammatory markers, except now with colchicine, okay? And I want to circle back to that in a second, except to treat LDL. And we do know that the lower we get the LDL, the lower C-reactive protein, CRP,
Right.
Levels are, and other inflammatory markers. So there's clear association,
Yeah.
but no independent association to add it as a risk factor other than hypercholesterolemia, high blood pressure, diabetes, family history of cigarette smoking. I wanted to circle back to, I forget what I wanted to circle back.
Colchicine?
Colchicine, right. Even with colchicine, as we mentioned earlier, I'm not saying there's no association. I'm saying we didn't assess it in the trials. We just used colchicine as an anti-inflammatory to see if it reduced events. There wasn't an arm in the study to see if events would have been reduced equally or augmented
Got it.
by appropriate oral care.
Right.
And so that's the part. I don't want anyone to be defensive. Part of as I've been saying, I don't know what the answers are going to be. Part of doing research is sometimes you spend a lot of your time and you think you're on the right path, and then there's not a clinical or a marketable utility for what you've been doing. Doesn't mean that what you've done is not important.
Right.
It adds to the literature, it adds to our understanding, and that someone who comes after us looks at what you've done, right? How do we know if we're valuable in science, right? As if the research that we've published is cited.
Yes, of course.
You see my point? Mm-hmm. But these are the challenges. These are the challenges. So I think we're on the right track.
I do too. I think that having that oral assessment for these clinical trials, at least you would be able to go spelunking into the data to stratify on oral inflammation to see if your groupings had more improvements with no oral inflammation versus...
Or even just registries.
Right. Yes,
and
absolutely.
Again, going back to the fact that dentists are largely, dentists are playing tennis. They're not on a softball team. I mean that only in terms of their individual dentists. Mm-hmm. It takes a lot of effort, organization, and administration. Then you ask yourself the question, where does the funding come from?
Right.
Mm-hmm.
Okay. So even if you just did a registry where, patients come as they want for oral hygiene care, patients that you require them to come once a year, and patients you require to come, every quarter.
Yeah.
And then follow them over 1, 3, or 5 years. And it'll just be interesting, get baseline labs, inflammatory markers, and do that at every 6-month or 1-year interval. That's how you start getting a better understanding of what the impact is. Or is it, again, just lower LDL? You see my point?
I do.
Making the connection of why it happens. No, you're exactly right. We have lots of studies that suggest, but we don't have anything definitive that actually connects. And that's the challenge, and that's what I'm a little bit afraid to say to all the dentists, to be quite honest with you, because I'm not looking to offend anyone. Mm-hmm. But that's really the challenge. In terms of something that can happen now, sleep apnea issues, obstructive airway issues, especially in an obese society, right?
Yes. Getting
more involved even in weight loss management, whatever they think the treatments were. I even think I even believe they need to rethink that or be open to the fact that, you can put people on these, semaglutide, the Ozempics, the Wegovys, and, there's a good chance they lose 15% of body weight. It would be interesting to repeat sleep studies after that.
Absolutely.
Right? Does that have an impact on it? That's not going to take away airway obstruction per se, but it might help
alleviate some.
Mm-hmm. Right. Yeah. And so that's my point. We have a long way to go.
We do.
We're at the beginning. This Totality of Care Symposium, all the work they're doing, all the work you're doing, podcasting about it, that's the way you start a movement.
Exactly.
And it's, but it's always a long road.
Indeed.
Costly,
Yes, it is.
painful,
Painful,
and
yeah.
time-consuming. Education always is. So,
Will you be at AASH in September?
not sure yet.
Okay.
I'm not sure yet. I certainly haven't been invited to give any talks, but I'm not sure yet. This is, as you know, kind of from April, May through September is conference season.
Yes, of
Yes.
course.
In a sense,
Yeah.
and we between all of, this work and the fixing arteries work, which I
Yes.
actually still do.
Yes, still
And there's still
working
a
on
lot
the
of that
ground.
work out there. It actually keeps us quite busy. But I can tell you, we're working on a number of things. We're trying to come up with ideas on things to look at. We've looked at some of the individual data, oral flora data that Dr. Pritchard has had, Dr. Avis has. But it takes time trying to figure out what the right thing to focus on. And again, the Wizard trial, which was the azithromycin in patients with chlamydia pneumonia in their blood, that didn't discourage me. That always made me feel 20 years later like we left something on the table there.
Mm-hmm.
That there just wasn't the interest. I guess there wasn't a financial gain for the pharmaceutical company. It would have taken too much time to pursue it further, because initially there was a separation and there appeared to be a benefit. So I think maybe we just didn't get the dosing right or the duration right, or didn't know how to, other than the hard endpoints.
Didn't know what else to address. Yes.
There was no dentists involved in that.
Exactly. Yes.
And so that's my point. Maybe there's a clear connection and we just haven't looked for it.
Absolutely.
Right? How
Yeah.
often does that happen, right? You can't find your glasses and you never check the top of your head.
Right.
You put them up there.
Well, I think so. All of the dental assessments so far have been subjective. We measure with a stick, poke and prod, and really rely on the clinical evaluation. So I think as we get less subjective, more objective measures, and those are coming, we're getting more inflammation assays coming to market soon. I think that it'll be easier for somebody like you to get an oral assessment picture that is cheap and easy chairside just by saliva. And so I'm looking forward to that kind of full cohesive story that is accessible to anyone. That you don't necessarily need a dentist on site to do this kind of holistic assessment. And then, of course, refer out to your colleagues.
Yeah, so I think that I'm in complete agreement, and I think that kind of brings us to my conclusion. I don't think it's been totally subjective. I think there is some objective evidence. There is epidemiologic evidence. There is
Sure.
no question about it, right? We have studies that show patients who have heart attacks have more periodontal
Yes.
disease,
Yep.
and vice versa, by the way, right? People with moderate to severe periodontal disease, right? I showed some studies today, or I'll show some studies later today.
Right, and oral bacteria in the plaques.
Right.
Absolutely. But that's the point. We have to make it more objective. Getting it to a quick and easy way to assess
Yes.
and treat, I think we're a ways off from that.
I
But this
agree.
is the way we approach, but
Yeah.
this is the scientific method. This is the way you have to approach it. And if we keep having the dentist in one room
Yeah,
and the cardiologist in another room, and they don't even know they're on the same campus,
right. Or with the same patient even. Yeah.
then that's going to make it a lot longer.
Yeah.
So I think there's lots of things we can do, and that's why I'm humbled and flattered to be here. I'm learning a lot,
Yeah.
and I'm trying to I don't want to say impose, but I'm certainly trying to expose all of the physicians in our group to this to make it's certainly getting them thinking.
Yeah, well, that's the first start, is
Yep.
solving the
Right?
puzzle, right?
It's getting them thinking. There's no question. They Dr. Avis, they scratch their head about, like, how does he find all this stuff? You know what I mean? Like, how does he, and his patients have benefited from their dental exam.
Right.
They're living longer because they went to the dentist in some way. Now, connecting all of that, making it objective, and then putting it in a package, right? How do we give, protocolize it for other practitioners? We got a lot of work ahead, but that's what makes life exciting. That's what makes our professional life interesting and gets us up, wants us to get up in the morning, right?
I agree with you.
You look forward to
Yeah.
it.
Not every practitioner is like that. So I'm excited. I'm just happy to be here where everybody really is engaged and curious and keeps asking.
There's no question about that.
Yeah.
They are clearly interested, excited, and want to make a difference, right?
Yeah.
So that's step one.
Yes, that's why we're here. Well, thank you so much for sitting down with us today. It's been an absolute pleasure. Where can we find you out in the world?
My main location is on Wall Street in Manhattan at 120 Wall Street, or at Sorin Medical, SORIN medicalny.com. We're on Instagram, Sorin Medical NY, and we're just trying to do our part to improve access, have high quality, and reduce costs to democratize healthcare.
Yes,
Everybody deserves good healthcare.
Absolutely.
And the best life they can live.
Thank you.
Thanks so much for having me, Camille, Jonathan. I really enjoyed it.
Likewise.
Look forward to furthering this conversation.
Same.